ID Committee for Iowa AAP. I'm extremely honored to present this webinar today on Mycoplasma pneumoniae infections, which was actually on demand by some of our members who had, who are seeing an increased infections in various parts of the state and nationally as well. So I think it's a very timely topic, and I'm honored to talk to you. Thank you so much. So Mycoplasma pneumoniae is common infection. So the objectives of today's talk will be to discuss the epidemiology and the recent trends of Mycoplasma pneumoniae infections that have been increasing during 2024. We'll also talk about clinical presentation of these infections and discuss the Centers for Disease Control and Prevention, as well as American Academy of Pediatrics recommendations for management, diagnosis, and treatment of these infections. I have no pertinent disclosures as applied to this particular presentation. So when we talk about epidemiology, mycoplasmas are ubiquitous, free-living, tiny organisms that belong to the molecules category. They are considered to be bacteria, but they actually lack a cell wall, and that's the chief difference. They are ubiquitously found in animals and plants, but Mycoplasma pneumoniae disease only occurs exclusively in humans. They are transmissible by respiratory droplets during close, prolonged contact. And outbreaks have been described in closed settings like, hospitals, military bases, nursing homes, colleges, and summer camps. It is the leading cause of pneumonia in school-age children and young adults, but traditionally has been thought to be an infrequent cause of community-acquired pneumonia in children younger than 5 years, although, as I will show you, the recent trends show us increased prevalence in the younger age groups, and that's what has been concerning. But traditionally, it's like more than 5-year-old, 5 to 17 is the most commonly involved age group in pediatrics. In the United States, approximately 2 million infections occur almost every year. So it's a pretty common cause. Approximately 10 to 20% of all cases of community-acquired pneumonia in hospitalized settings are usually attributed to Mycoplasma pneumoniae infections. Occasionally, it can also cause hospital-acquired and ventilator-associated pneumonia. Infections occur throughout the world, and usually, they can be seen in all geographic settings as well as occur in any season. More prevalence has been seen in fall, although, in some of the seasons, according to the CDC. This year, however, they started seeing the increased prevalence during summer months, and I'll talk more about that. Approximately 30% of household contacts will develop pneumonia, so an attack rate of 30% is seen as with this organism. Asymptomatic carriage may occur for weeks to months, so a very prolonged carriage period, as well as not a very long-lasting immunity, so they can get to infect recurrently. Also, the incubation period is pretty long. It's 2 to 3 weeks, and it ranges from 1 to 4 weeks. So all these factors can contribute to lengthy outbreaks. So as I was mentioning, every 3 to 7 years, CDC has noted cyclical increase in Mycoplasma pneumoniae infections. And since COVID-19, though, this has been the first time that we are seeing such a high increase. So during COVID-19, as we know, basically, like other respiratory pathogens, Mycoplasma pneumoniae had declined substantially because of the infection prevention measures, social distancing, hand hygiene, etc. But beginning in the fall of 2023, China and other Southeast Asian countries started to notice a reemergence of this bacterium, and this trend has followed globally. So this is shown in this graph, as we can see, like, reemergence seen towards the end of 2023. What's happening in 2024? CDC has seen a tremendous increase in these infections. And there being no national reporting surveillance system, they really rely on the reporting that's seen in the ED, in the form of ED admissions or hospitalizations. And then so CDC started noticing these infections more often from summer of this year. So they started noticing an increase during 2024, and the most important part was that they also started noticing these infections to be occurring in younger children. This certainly differs from previous years in which majority of infections were observed in older children and adolescents. But this year we are seeing 0 to 1 year olds and 2 to 4 year olds being affected. And I'll show you the graphs, and the graphs look pretty dramatic. And they also, as I mentioned, started noticing that these trends to emerge from late spring, early summer of this year. So as we can see from this graph from the CDC, the 5 to 17-year-olds have always been the peak group of occurrence. However, as we can see here, the younger kiddos seen in the orange line, denoting the 2 to 4 year old age group, that really surpassed them. So this has been like really the most commonly affected age group this year. And also the younger kiddos, 0 to 1 year old, the infants are also, pretty highly impacted. So this year, emergency department visits, CDC noticed that obviously they increased in all the ages, which is post-pandemic rise and reemergence of this bacteria, but majorly seen in the 2 to 4 year olds, and that has jumped from 1% to more than 7%, going up to 10% actually. And 5 to 17-year-olds has also seen an increase. So this bacteria circulating pretty commonly in our community. So much so that CDC released a health advisory and a bulletin saying that majority of these infections are usually considered to be mild, except in certain high-risk children, especially immunocompromised children, and especially in children with some kind of pre-existing hemolytic disorders like sickle cell disease, and also in younger children. Outbreaks usually have to be suspected in crowded environments such as schools, college, residence halls, and nursing homes. And this is unique because it can lead to prolonged outbreaks because of a long incubation period running into a matter of weeks, and the ability of the bacteria to persist in the respiratory tract for several months, as well as the prolonged presence of symptoms such as coughing, which may last for almost 3 to 4 weeks. And CDC also says that patients who spend a lot of time with someone who's sick with Mycoplasma pneumoniae are at increased risk, rather than short bursts of a very short contact won't really risk such a large risk of infection. However, a prolonged contact with somebody who's sick will entail a higher risk of getting sick. The age and crowded settings, they are the most common risk factors. So as mentioned, most commonly seen in young adults and school-age children. And as we are seeing, they are also seen now in infancy and in 2 to 4 year age group. Crowded settings, certainly living in crowded settings such as college, dorms, detention, correctional facilities, hospitals, long care facilities, schools, etc. And they spread by airborne droplets through close person-to-person contact. And so what are the clinical manifestations? Mostly the respiratory tract is the most commonly affected organ in the body, but there are many extrapulmonary manifestations, which we'll talk about in greater detail. But amongst the respiratory tract, there will be upper respiratory and lower respiratory involvement. And pneumonia and tracheobronchitis are the most commonly, the most common manifestations.
Thing.
But the bacteria can also cause wide array of extrapulmonary manifestations. So acute otitis media, it's not that common. And bullous meningitis, traditionally known to be pathognomonic for Mycoplasma, is known to occur with many other organisms, but this particular organism has been famous for causing that. Acute bronchitis, upper respiratory tract illness is usually might be mild and self-limited. Sinusitis and croup might also be seen rarely. However, approximately 1/4 of the infected children will develop pneumonia, and they will have coughing, fever, sore throat, malaise, coughing in the first week, and then they'll have growls on examination, mostly developing towards the end of first week, going on to the second week. And mostly they will also have a chest X-ray showing the bilateral infiltrates during those initial weeks. Cough, initially non-productive, can become productive, and it can persist for 3 to 4 weeks. So I said it's like can be very prolonged, and also can be accompanied by wheezing, mostly expiratory wheezing. And approximately 10% will have a rash, which is mostly a maculopapular. So can be confused with a viral illness as well. But as we can see, some of the kids can get very, very sick with this. Mostly they can be mild and asymptomatic. So radiographic abnormalities are common, and they can include either bilateral diffuse infiltrates or can even have focal abnormalities like your typical bacterial pathogens like consolidation, pleural effusions. These are mostly seen in immunocompromised hosts. They can also have hilar adenopathy. So the extra pulmonary symptoms, these are unusual but can be serious. So central nervous system is the most commonly affected extrapulmonary organ system, and it can occur in as many as 5% of the affected patients. So nervous system disease can be seen in up to 5% of the affected individuals. Most commonly, we can have manifestations like aseptic meningitis, encephalitis, or ADAM, cerebellar ataxia, or even transverse myelitis and peripheral neuropathy. Sometimes it can be direct bacterial invasion, and sometimes it can be a manifestation of autoimmune or post-infectious immune complications. The other systems that are affected include cardiovascular systems. So we can have myocarditis and pericarditis, arthritis, and these are particularly seen in immunocompromised hosts. Skin manifestations are also pretty notable. They include erythema nodosum. So this is one of the rare causative organisms that can cause that. Also, polymorphous mucocutaneous eruptions that can be serious can be seen, including SJS syndrome or RIME, which is reactive infection mucocutaneous eruption. It was formerly called Mycoplasma-induced rational mucositis, but its name was recently changed. And hemolytic syndromes can also occur, like hemolytic anemia, thrombocytopenic purpura, and post-infectious glomerulonephritis has also been seen to be occurring, especially with immunocompromise. Severe pneumonia with pleural effusion can occur, especially with people having pre-existing problems like sickle cell disease, Down syndrome, immunodeficiencies, and chronic cardiorespiratory disease. And acute chest syndrome and pneumonia have been associated with sickle cell disease. So this is something to be kept in mind because these are some of the hosts in whom we might consider prophylactic antimicrobials as well. And I'll talk about that. Again, it is a commonly implicated organism known to be associated with exacerbations of asthma in as many as 20% to 50% of individuals. So Mycoplasma pneumoniae carries many unique features. As I was mentioning, it lacks a rigid cell wall as opposed to most of the other typical bacterial pathogens. That's why it's like called an atypical, one of the atypicals. And so that's why you use some other additional class of antimicrobials to treat this, not your regular beta-lactams. Beta-lactams won't work because it doesn't have a cell wall. It can associate closely with host cells. It can produce a toxin and can replicate intracellularly. And we'll see how it impacts its pathogenicity. So all these features, they tend to give certain challenges while treatment of this particular bug. So lack of cell wall impacts treatment options. For instance, I was mentioning beta-lactam antimicrobials will not work against these bacteria like your regular cephalosporins or your penicillins because these are cell wall active agents. Also, the close association helps bacteria not only survive, but also, it can lead to innate immune responses and produce local cytotoxic effects. Toxin production aids in colonization, especially the community-acquired respiratory distress syndrome toxin. And also, some people believe that it leads to highly inflammatory disease as well as airway dysfunction. And since it offers the ability to be endocytosed also offers unique challenges because it can help establish a latent or a chronic disease state. It can lead to recurrent infections, and it can also facilitate evasion of host immune response and interfere with efficacy of antibiotics. So several unique challenges with this organism. And this is an electron microscopic picture to show this typical, the bulbous tip, which can help in attachment and it's in close association with the respiratory epithelial cells. So what does, how do we diagnose this? So as I was mentioning, this doesn't have a cell wall. So really you cannot really see it under the light microscopic, in the examinations. You cannot stain it by gram staining. Typically does not stain very well. So light microscopy cannot detect them. And while working in the microbiology lab, we need to be aware of these unique features. And so it has to be handled a little bit differently from other bacteria. They can easily pass through filters that are typically used to remove bacteria. So that's unique. And again, they don't produce any visible turbidity in liquid growth media. In order to achieve visual confirmation, they have to utilize specialized media, especially special agars have to be used like SP4. And that can also take a prolonged process, like it's a longer than a few weeks to confirm. So although can be diagnosed with culture, serologic testing was much in vogue. Nowadays, molecular testing has taken the lead. So molecular tests such as nucleic acid amplification tests are the gold standard to diagnose this. And we are very thankful that these have been made available in the last decade or so. They offer high sensitivity and specificity. They provide timely results. And if needed, they can also help in predicting the antimicrobial susceptibilities by genotype. So usually the regularly available tests available to clinicians will detect this pathogen. And if you need further information on susceptibility testing, then the public health laboratories as well as CDC labs can help out. We can talk about the other methods as well, but we'll first focus on the nucleic acid amplification test. Multiple tests are available through the FDA. FDA has cleared many tests. And as I said, this is the preferred method to diagnose, and the clinical and reference labs can both provide, these kind of testing. So mostly the NATs that are available, they can detect multiple respiratory pathogens, including M. pneumoniae. So some can be just M. pneumoniae PCR, but others can be, a multiple pathogen testing platforms, such as the respiratory viral panels, which we are using commonly these days. And CDC actually prefers using a multi-pathogen testing platform, like, a viral panel or a film array testing platform where you can detect multiple pathogens because during the winter season, as we know, there'll be increased respiratory illness in the community anyways, especially among children. So it's useful to detect if anything else is also circulating. But that's what is the preferred method. And actually, it has a very fast turnaround time compared to the other methods. So they can be performed, NATs can be performed in multiple specimens. So either you can send a nasal wash, nasopharyngeal swab, oropharyngeal swab, sputum, or a BAL a fluid. They are all considered to be adequate specimens. The testing usually is very rapid, and that's why they have commercially made available and also have been replacing all the other methods of testing like culture and serology. Because of this rapid turnaround time, mostly the test can be made available, the results can be made available the same day. They have a very high sensitivity and specificity, ranging between 80% to 100%, and they yield positive results earlier in the course of illness. So that's also an important thing to consider. Serology usually would take a week or so to become positive in an infected patient, while the PCR testing can be done as soon as you suspect the illness, as soon as the symptoms appear. As I mentioned, several assays are available, and mostly you have to have a clinical correlation. So NATs are extremely sensitive tests, so will also detect colonization. So if you have a clinically, appropriate illness which matches the clinical symptoms in that particular scenario, if you have a positive NAT testing, then that gives us a very high positive predictive value. And that is most useful. However, since they are very, very sensitive tests, CDC cautions that if there is a non-classic clinical disorder, then we might be, attributing it to Mycoplasma pneumoniae in case because of this high sensitivity. And that has been seen in some asymptomatic patients as well. For serology used to be available and used to be, the preferred test many, many years ago. And because that was the only one that was available to us. So immunofluorescence and enzyme immunoassays are the most commonly used in that area. IgM, IgG antibodies are the most commonly detected. So IgM antibodies may indicate a recent infection. However, they are not detectable within the first 7 days after onset of symptoms. So only after 5 to 7 days can you, if you send it, you can have it positive. Also, they may not really, if they return positive, then they may persist in the serum for several months or even years. And so they might indicate recent infection, but they may not be very indicative of an acute infection. also not highly reliable to detect recurrent infections. And so serologic diagnosis is best accomplished by actually demonstrating a four-fold or greater increase in IgG antibody titer between acute and convalescent serum specimens, which is actually a labor-intensive thing because then you have to keep calling the patient back to draw these titers. So again, more labor-intensive, certainly, and less beneficial than the NATs. Previously, we used to rely on complement fixation assays and the cold hemagglutinin titers. These are mostly microbiological techniques which are no longer preferred, but they are not that specific as compared to the NATs, but they are still available in some areas. So how would you collect the specimen? So as I was mentioning, there's several options. Some people, some studies have shown that oropharyngeal swab is a better yield than nasopharyngeal. So ideally, CDC says that you should consider swabbing both the throat and the nasopharynx to improve the likelihood of detection in respiratory swab specimens. And adherence to proper specimen collection technique is extremely important for accurate test results. So for an oropharyngeal swab specimen, you should insert the swab into the posterior pharynx and the tonsillar area and be sure to rub it vigorously over both the tonsillar pillars and the posterior oropharynx, and also avoid touching the areas of tongue, teeth, and the gums. For nasopharyngeal, you have to insert a thin, flexible swab through the nares parallel to the palate. And then once you encounter resistance, and that is where you swab it. You gently rub and roll the swab. So again, prefer to send both of them. If you can only get one, then oropharyngeal has shown to be a slightly better. But again, CDC tells us to get both if possible. Now, sometimes I mentioned that you can, CDC is encouraging practitioners and through the public health labs, through some children health network, hospital network systems to send to them, especially when they're concerned about antibiotic resistance. And I'll present the data. It's nothing, so far we are not seeing so much resistance, but I'll show you the exact numbers. But then again, they are encouraging providers to send specimens if they can and if they have any questions. So the way to send the specimens to the CDC is through state public health lab. So because CDC only accepts specimens from from those organizations that is accepting right now at this point. And then CDC doesn't use culture or serological testing techniques. It's only using NATs or the molecular testing methods. And also they are mostly concentrating on antimicrobial susceptibility testing. So what about treatment? So when we are seeing an increased circulation of this pathogen, first of all, we should decide whether it's a mild disease, if the patient is really not really sick, whether you need the antibiotics or not in the first place. So antimicrobials have been most likely shown to shorten the course in severe disease. So if you start the antimicrobials within the first few days of illness, then they have been known to shorten the duration of fever, as well as known to decrease the progression to severe disease. And that's been shown to be like beneficial use of antimicrobials. Now, if there are only upper respiratory tract illnesses or really non-severe illnesses, then, you might, see and observe the patient without any antibiotics. But if they are febrile, if they're really sick looking, or they have pneumonia, which usually are considered to be severe infections, then you might treat the patient. The usual course for pneumonia, as you know, is 7 to 10 days, sometimes even 14 days, but exception is azithromycin use for these patients, for which the course is 5 days. Okay, so only for azithromycin you can give a 5-day course, but other than that, for all other antimicrobials that I'm going to show you, the course is usually longer. And definitely treat severe extrapulmonary manifestations. So definitely if you have a patient with central nervous system disease or septic arthritis, or you have an immunocompromised patient or a patient with sickle cell disease having a mycoplasma pneumonia infections, in any of those high-risk hosts, we are supposed to treat. It's an expectation that antimicrobials will help shorten the duration and severity of disease. So as I've mentioned, because mycoplasmas don't have a cell wall, they inherently are resistant to our beta-lactam agents, which are our most commonly used agents. So then you go to macrolides. Macrolides, which include azithromycin, clarithromycin, and erythromycin, they are your preferred first-line antimicrobial agents for treatment. And then again, as I said, especially those with underlying conditions such as sickle cell disease and certainly those with moderate to severe infections, do go ahead and treat them. You give them a 5-day course of azithromycin, just like you would 10 mg per kilo followed by 5 mg per kilo for the rest 4 days. So day one, 10 mg per kilo followed by 4 days of 5 mg per kilo. So that would be like a total 5-day course. And in older children, you can do the Z-Pack. So that's what you should be doing as your first line. Macrolides are still considered to be the drugs of choice. You don't need to go to a second line because the rates of resistance in the United States are pretty low at this point, and CDC is really saying that these are our first line agents. And I'll show you more data regarding that. But so these are your first lines. Now, what other antimicrobials work against Mycoplasma pneumoniae? So cephalosporins don't work, penicillins don't work, they're out, but fluoroquinolones and tetracyclines are the categories which you can use if you are suspecting resistance. And then another class which is only used for people 18 years and older is fluoromucilins, which includes antimicrobials like lefamulin. This is also one of those antimicrobials, just like macrolides. It has a spectrum kind of like macrolides, but also includes gram positives and covers MRSA. So that's interesting about this class. But these are the other three classes which can cover Mycoplasma pneumoniae. Treatment of hospitalized children attributable to a macrolide resistant strain should be treated with fluoroquinolones, and that has really shown to reduce the duration of fever and as well as duration of hospitalization. So definitely treat anybody who's hospitalized with this bug as well as people who have underlying diseases like sickle cell or immunocompromised. Uh, Now, I was talking about antimicrobial resistance. So you don't use fluoroquinolones as your first line. Okay, you don't use tetracyclines as your first line. You only use them if you're suspecting macrolide resistance. So CDC is tracking resistance among these isolates, and monitoring usually occurs when you submit the specimens, and that's done through the public health departments and from surveillance systems. Now, resistance first emerged in the early 2000s, and since then mostly has emanated from China and from Southeast Asian countries. And there's, the global prevalence has been seen to be around 28%. As we can see, there is significant geographical variation, as noted by the CDC. As we can see, in China, more than 80% strains are resistant. In Japan, more than 50%. Europe, averaging around 5%, and United States, overall, less than 10%. Now, limited data, shows geographical disproportionate, occurrences of resistant strains. So initially, the South and the East traditionally have been regarded to have more resistant strains, as much as 20%. However, this was the pre-pandemic data. I'll show you what's happening, like right now, what they are seeing. But overall, remember that it has remained low in the United States. Overall, it's remained less than 10 to 15%. So CDC recently came to Pediatric Pandemic Network, which is a DHHS-supported forum which connects different children's hospitals, and I'm on the ID advisory board for that. And so according to our discussion with the CDC, as I was mentioning, mostly the resistance is currently being seen mostly in the Eastern Asian countries and in China. But the CDC mycoplasma infections have really increased since the pandemic, and they are looking for more, manifestations like cutaneous and encephalitis. They are seeing that emerge in certain parts of the country. The resistance rates for most parts in the United States have remained around 10% and under West 5% in the Midwest. So thankfully, not that much resistance for us. But they are seeing more resistance emerge in the West Coast this time. In 2012 to 2015, there were more, reports of resistance in the eastern and southern regions of the United States, but currently they are seeing the trend in the West Coast. Also, macrolide resistance, as I mentioned, is the main thing that we are worried about right now. There has been no reported resistance to tetracyclines or quinolones anywhere in the world. So that's pretty reassuring. And so I would really say that that's, we should be thankful for that. So there's no resistance to this, only macrolide resistance. But again, that's pretty low. So we can still go ahead and treat with macrolides for most part. Also, they are tracking, the CDC is really tracking the 2024 how this organism is behaving, because this is not a nationally notifiable disease, as I mentioned. So they are really trying to see what outcomes are there compared to pre-pandemic, and if there have been, what is the demographic, distribution as well as severity of illness, etc. So that's why they are requesting the Children Hospital Network to continue contributing data in terms of, specimen collection and such. So that was, I just wanted to bring it to the group to make aware about what's happening at the ground level. So what about infection prevention and control measures? So whenever you have a patient admitted with Mycoplasma pneumoniae, you usually put them, in addition to standard precautions, you also follow droplet precautions for the duration of symptomatic illness. And of course, you'll follow other respiratory etiquette as well as hand hygiene. The hand hygiene will decrease household transmission, and just like other respiratory pathogens should be encouraged. Also, as I was mentioning, there is also a recommendation for prophylaxis for close contacts, but only those who are immunocompromised and also having patients with, children with sickle cell disease. So in those settings, prophylaxis with a macrolide or a tetracycline can be considered for patients who are at increased risk of severe disease with Mycoplasma pneumoniae. And in those groups is where a prophylaxis is encouraged. In asymptomatic, generally healthy individuals, prophylaxis is not generally recommended. So the recommendations from the CDC, when they released the bulletin recently, they want us to consider Mycoplasma pneumoniae as a possible cause of infection, hospitalized with community-acquired pneumonia. And then they are also, emphasizing the need to have an increased suspicion for Mycoplasma pneumoniae among patients with community-acquired pneumonia who aren't clinically improving on antibiotics that are known to be ineffective, like beta-lactam. So usually, if you have a patient with community-acquired pneumonia, a small child, you can probably put them on amoxicillin, just like a drug as a drug of choice. But if the patient does not improve on that, then you should suspect something atypical, usually Mycoplasma pneumoniae in this setting, and then try to give them a trial of macrolide. So also, use azithromycin either in conjunction or after a trial of the usual if the patients are not improving, because we are seeing a lot of circulation in the community. Also, when you are trying to start them on the medication, you should swab both the throat and the nasopharynx to improve the likelihood of detection of this particular pathogen in respiratory swab specimens. And so you should try to take both. Oropharyngeal is slightly better yield, but then you should use both if possible. Macrolides, as I mentioned, are the first line agents. The rate of antimicrobial resistance is still pretty low. But if patient is not improving and is hospitalized and is sick, then you can go to a second line agent such as fluoroquinolones or tetracyclines. Again, promoting judicious use of antimicrobials in the setting and minimizing the risk of resistance by not prescribing unnecessarily, unless indicated, unless really having a severe disease or really not improving, and having clinical as well as lab evidence if you have. Of course, we should follow the co-prevention strategies. This is really neat. This has been recently clubbed together by the CDC, and this nicely brings together like what is the hand hygiene practice and how do you cover your coughs and sneezes. So it's a nice little link. So in summary, to take home points, there's no national reporting system, there's no surveillance system. So if you're seeing an increase in your area, you should certainly bring it to the attention of the public health department, and they can forward the specimens to CDC for detection of resistance. Also, Mycoplasma pneumoniae infections, as I mentioned, are pretty common, but usually they are mild and asymptomatic. But in 2024, we have seen an increase in Mycoplasma pneumoniae infections. We are seeing that in younger age groups, especially in the 1 to 4 year age group, which is concerning. And they have also seen community-acquired pneumonia to be increased in those settings. So you have to suspect them in younger children as well. The oropharyngeal and nasopharyngeal swabs I mentioned, molecular testing methods are the diagnostic methods of choice. So remember that. Not using serology as much anymore. And the clinical reference labs can provide diagnostic testing, including like all three are available, but then molecular methods are the ones that are preferred. They are the methods that are preferred. Um, and as I mentioned, treatment with macrolides, including azithromycin, is your first line agent, first line therapy. The other treatment agents, if you are using, they will lead to prolonged treatment. Like, their usual ranges of duration are usually more than a week, so 7 to 10 days minimum. But with azithromycin, you can treat it 5 days. That's usually the course. Antimicrobial resistance remains low in majority of the parts of the United States, less than 10 to 15% for most part. And then again, follow hand hygiene practices. If you are surrounded by sick people, you should have like the coughing etiquette, always cough in your sleeve, and then not really, going out if you're really sick. Especially with the holiday season approaching, I think we need to have these infection prevention guidelines in mind. And again, vaccination, I always throw it in. Mycoplasma does not have any vaccine that can, there's no vaccine to prevent it, but we have vaccines to prevent other diseases like influenza and, thankfully RSV immunization is available for younger children now, and COVID. So anything, that you can protect yourself against, please get vaccinated against those respiratory pathogens at least. And for this, just keep your, a high index of suspicion. And these are the resources. So lots of resources have been put out by the CDC to help, clinicians recognize. They have even, these are some of the programs with which they have collected the data and showed us that they are really increasing in, numbers. And also for public knowledge of specimen collection, they have included some nice links, and they have included some video links here, which was pretty cool. So I've included all this here in case you are interested. And with that, I'd like to thank you for your kind attention and would like to take questions if any. Thank you so much.
Thank you so much, Dr. Kaushik. Does anyone have any questions